this week's edition of our What's Up Doc series, where we spotlight outstanding medical professionals in our community. Today, we're thrilled to introduce Dr. Ashkan Karimi, a distinguished interventional cardiologist serving patients in Northern Virginia. Dr. Ashkan Karimi is a board-certified interventional cardiologist with extensive experience in treating complex cardiovascular and vascular conditions, the heart, the abdomen, the legs, and even beyond. He currently practices at Inova Health System in Virginia, where he specializes in minimally invasive procedures to diagnose and treat heart and vascular diseases. But I believe, Dr. Karimi, do you have office-based labs as well?
Yes.
Or are you just
I'm
hospital
part
based?
of Carry and Heart and Vascular, and we also have our own procedural suite that a lot of the limb salvage work that we do is done at that procedural suite.
Oh, fantastic. And so what is your primary focus? Are you doing 90% legs, 10% hearts? What is the breakdown of where you spend most of your practice?
Yeah, I would say my practice involves a broader spectrum of, like you said, cardiovascular conditions, but it's more geared towards vascular at this stage. I'm doing, and it has shifted since I graduated, but right now I'm probably doing 70% more vascular, which involves, I'm also, wound care certified, and I'm the medical director of UVA Prince William Hospital Wound Care Center, which I see a lot of my patients have wounds, either arterial or venous mix. And so I think a lot of my practice, quite about 70% of it is really vascular and peripheral vascular disease and wounds and venous ulcers, that sort of thing.
Oh, fantastic. So you do just a little bit of everything, which is great. Why are you so passionate, though, about CLI, critical limb ischemia?
So, that passion actually started when I was a fellow. And at that time, there was a course that I went to, and it was mainly focused on limb salvage and chronic limb-threatening ischemia patients with very advanced vascular disease. And one of the slides that was shown in that presentation is that if you look at the life expectancy of a patient when they get diagnosed with advanced stages of peripheral vascular disease and chronic limb-threatening ischemia, actually the life expectancy is shorter than a lot of cancers. There are really very few cancers that have worse life expectancy after they're diagnosed compared to chronic limb-threatening ischemia. And, I always talk to my colleagues, when we go in at 2 a.m. in the morning and we have a massive heart attack, usually these are quick procedures. The next day, patient probably doesn't know you or what happened, but, you have obviously done a great work. But in limb ischemia, a lot of these patients have long-standing wounds. They go to the wound care centers 2 or 3 times a week. They're in a lot of pain. You really become your lifetime, advocates and friends when you really help them and recover. And if you're really preventing amputation, that's one of the most rewarding things that we can do. A lot of the patients, either young or elderly, usually the quality of life of after major amputation is just so miserable. Even if you don't look at the life expectancy after, just the quality of life itself. And these are very complex decision makings. When you have a wound that's not healing, that's why I invested so much time in wound care and understanding the wounds, because really not just about opening the arteries a lot of times, really understanding the dynamics, the foot unloading, your close collaboration with your foot doctor, your plastic surgeon that does reconstructive surgery afterwards is really critical to have the outcome that everybody hopes is just preventing a major amputation.
And we do have a live studio audience, guys, if there are glitches in the audio. So I do apologize about that, but I'd like to get to the live studio audience. I want to start with Douglas. Douglas, go ahead and unmute and ask Dr. Karimi the first question of the day.
So my question pertains to kind of like a mixture of both. I have atypical hydrotrophic cardiomyopathy, and I have PAD also. And I was looking up today the calcium and what that thing that was in the handout about calcium and how that play a major role between the two of them for me, and keeping that under wraps and in charge so it doesn't affect my heart or my legs.
Gotcha. So Douglas, I heard that you have atypical hypertrophic cardiomyopathy. Is that right?
Yes, sir. I had a myectomy a little over a year ago.
Gotcha. And do you have any other cardiovascular condition other than?
I have a pacemaker.
Okay. But no history of blockages in your heart or leg arteries, right?
Yes, I have a couple bypasses that are blocked.
You're cutting out. Can you say that again?
Can you hear me?
Douglas, go ahead, please.
I have an aorta bifemoral bypass and an axial bifemoral bypass. Both of them are blocked, but I've had work done around them. So I'm really trying to learn to eat properly and watch my cholesterol and all of that. And I was wondering how my calcium will play a major role in that.
Yeah, I got you. So, you have had an aorta bifemoral bypass and an axillary bifemoral bypass. Both of them are blocked. And you don't have any wounds or anything, right?
Right.
No, they were
But you
able
probably
to
just
go into true lumen. They were able to recanalize the native vessels. They were able to recanalize one of the branches of the aorta bifemoral bypass to one leg.
Gotcha.
And they were able to stent that. The other one, they were able to go in through natively to open that up. And so he has no need for the axillary.
Gotcha. Thanks, Kim, for filling me in. But Doug, to answer your question, you're right about that. That a lot of these plaques, there is calcium deposition, within the plaque. So plaque usually have a core that is the lipid and fat, but then that lipid causes inflammation, and the process of the natural body process is that they deposit calcium whenever there's inflammation. So those plaques become calcified and really hard. That's part of the problem we have when we go through these long segments of blockage. Sometimes our wires or catheters don't go through them, or like Kim said, go around the blockage. We call it a dissection plane and try to kind of go around them and recanalize the vessel. But what's important is that your blood calcium level has nothing to do with the calcium that get deposited in that plaque. They're two separate processes. So a lot of patients come to see and say, well, my blood calcium level is not that high. Why am I having so calcium deposition in my heart or leg arteries? They're two separate, diseases essentially. And eating milk or anything high calcium content doesn't have any effect on it. What's important is, and we have learned it, it's really important to reduce your bad cholesterol, your LDL. For somebody like you, the target doc should be less than 55. We used to say 70. Now, especially my patients with advanced diseases like you mentioned, we really push hard to get the bad cholesterol less than 55. When you get, and it has been shown that the statins or some of the newer medications reduce the inflammation also within that plaque and just slow down this whole process of atherosclerosis. So to answer your question, things that you can do is, like you said, good lifestyle habits, not smoking, walking, a good routine exercise program, and uh, medication was really trying to you probably are on baby aspirin, but also on cholesterol medicines and really targeting your bad cholesterol to be less than 55 should be the target.
Okay, fantastic. And we do have some questions that came in before, so I'll pull that up right here. Here's one of the questions, if you can see it. I have an abdominal aortic stenosis. I'm a side sleeper. This side I'm laying on feels sore. I never had this problem before PAD. Could this be PAD related and indicate anything? And that is from Kim.
Yeah, so it is, anything when the vessels come out of the heart, including your aorta, including your abdominal aorta, if it's a stenosis, it's in the peripheral vascular disease spectrum. So to answer your question, yes, that is peripheral vascular disease. Now you have to look at really what is the area of stenosis. A lot of times, and what are the limiting symptoms? A lot of times, if the symptoms are not bad, you can really treat medically and just observe it. If the symptoms are really limiting, or if you have rest pain or non-healing ulcer, then you have to do an intervention. Especially if it's just typically this stuff are not just limited to a small portion of the abdominal aorta. They usually have some extension into the iliac arteries. So in order to answer like what needs to be done other than medical therapy intervention, we really need more data. What I can tell you is that sleeping on one side will really not have any effect on it. These are really what we call retroperitoneal structures. They are behind a very thick membrane between your spine and this membrane. And really by sleeping on one side or on the other side, this is just doesn't cause it or prevent it or affect its progression.
Okay, but in terms of, it's not about the progression, but is it an indication?
It is a peripheral
The
vascular
you're
disease.
feeling, if you end up where it just feels as though you can't sleep on that one side, is that any sort of indication that the stenosis might be getting worse? The blood flow isn't
No, usually
flowing as well.
aorta stenosis, they cause what we call a buttock claudication. Usually in the higher thigh in the buttock, when you walk, you get tightness or tiredness, and that really is an indication of a really high grade upper what we call inflow disease, which are the bigger arteries going to the gluteal muscles, but it usually you really don't feel it in the abdomen.
Marsha, go ahead and unmute and ask Dr. Karimi your question.
Thank you. Hello, doctor, and thanks for being here.
Sure.
And entertaining us with our questions. My question is kind of related to what Doug asked about calcium scores. I am getting ready to have my first one next month, and I'm not really sure why I'm having it. Does that have more to do with like osteoporosis, or does it have to do with my blood? I'm not sure. Oh.
Having a coronary calcium score down with the CT of your chest, right?
I'm sorry, I wasn't able to hear
the calcium
you.
score you're referring to? Is that a coronary calcium score that you're having of your heart vessels?
I don't know. It's a calcium score. I guess it is.
Yeah, I would imagine it's
Yeah.
literally it's the only thing that our patients are typically offered.
Yeah. So if it's a calcium score, what it is that this is, there is a study that was done, years ago, that we look at thousands of patients, and we look at really a spectrum of, when you get to a certain age, you will have some calcium deposition in your heart arteries, which has a bell curve shape. So what we use that for is that which part of the spectrum are you on? So when you do this, you'll get a score called Agatston score and a percentile. So you want to do what percentile are you in? If you're on the lower spectrum, that's a good reassurance that you're not developing early onset coronary artery disease or blockages in the artery. Now, if it's in the higher spectrum, then your cardiologist would decide what intensity of cholesterol medicine you need to be on to really slow down the progress. So it's a useful tool to use for what we call risk stratification. It doesn't tell you if that plaque or calcium is built up. Is it causing any narrowing of your heart arteries? Because you can have just merely calcium buildup in the wall of the artery without impinging the lumen of the artery and not causing any blood flow issues. But it's a good a screening tool for coronary artery disease or disease of the heart arteries, and a good tool to use to guide sometimes us in terms of cholesterol management.
May I ask a follow-up then? Because seeing as I am a PAD patient, an ex-smoker, I mean, I had a lot of risk factors.
Yeah.
Is it, How useful, like I have to pay for it out of pocket, which I don't mind if it's really useful, but I already think I'm a high risk. I haven't had a heart attack to my knowledge, but I think I'm already in that group.
So, Mark, have you had any stress test done?
I'm getting ready to have that too, but the insurance pays for that. They're not paying for this calcium score.
Got you. So you're probably getting a PET CT scan, right?
For my stress test?
Yes.
I don't know. I thought they were going to put me on a treadmill bed. I'm not sure because I can walk.
Yeah.
I'm not sure.
You are asking a good question because you can get so here's a very good question. I would probably, Marsha, not do a calcium score because of the reason you mentioned. Because if you are already a PAD patient, it doesn't matter. You are in the higher risk category.
Right.
You need to target the lower cholesterol. You need to be on a baby aspirin. So it's not a risk stratification. And like I told you, calcium score by itself, it wouldn't tell us anything about the blood flow to the heart muscle. So I agree with you. A calcium score in your situation would not change my management. If you're having any cardiac symptoms, I'll probably do, like you said, a treadmill exercise test, depending on what baseline EKG is. But a calcium score by itself, I don't think would be helpful for you because you are in the PAD category and already need to be on aspirin and cholesterol medicine.
Thank you.
Yeah, that's what I was wondering too. Thanks, Marcia, for asking that follow-up, because I mean, if you already have PAD, you possibly have CD, then what is right?
Yeah, I agree.
Yeah. If anyone else in the live studio can get to you, we do have some questions again that came in earlier that I'm going to pull up. The next one in the meantime. This one is our first vascular months of what she explains as pure hell. He didn't read her notes that she wrote, or when you're too young at age 46, PAD, your arteries are quite narrow, but women's always are, and nothing I can do about that. And it wouldn't cause you pain anyway. Still be PAD.
Sorry, Kim. I think at least I hear you very interruptedly.
Doctor,
but
can
I
you hear
can't
me?
see the question. Yes, I can.
Okay.
Yeah. So, it's funny. I just had a patient in their 30s that had PAD, but
Can you see the question?
yeah, I see the question, Kim. So, I think, this is a statement that you're too young to have PAD is a general blanket statement, but you can certainly be young if you have risk factors, diabetes that's not well controlled. You can easily develop advanced PAD at a young age. From the gist of the question, I get that she just has heel pain. She doesn't have any open wounds, which is good. I think you have to look at the whole picture. If you have a completely normal, what we call ankle brachial index and toe brachial indexes, and your arterial duplex is completely normal, then heel pain is probably not a vascular pain by itself. And if those are completely normal and you still have heel pain, probably better to see a podiatrist. So, there are a lot of causes. There can be a bone spur, there can be plantar fasciitis, there can be a lot of other non-vascular causes for foot pain.
Well, she said it. She didn't say heel. She said the full leg. She has left leg pain.
Left leg pain. Got you. I thought it was just the heel that was hurting. So it's really, it's really hard to answer this question because you don't get the clinical context. But the bottom line, and even if you do, as you know, Kim, if you even just do a simple ankle brachial index, you can miss a lot of, probably over 25% of them. And a more sensitive test would be an exercise ankle brachial index, and that's why I always combine them with an ultrasound to look at the individual arteries. But you really need to look at the whole pictures. If an ultrasound is okay, the ankle brachial index, and you're a young guy or lady, and no really risk factors, no smoking, no diabetes, then heel pain is probably not related to underlying vascular disease. You mentioned elevated D-dimer. D-dimer is a byproduct of body really dissolving clots, and it's very non-specific. If it's mildly elevated, there are a lot of things that can get it elevated. If it would be something that when we see it, we always think about potential venous clots, and if your leg is hurting, I hope it's not swelling, because if it's swelling and hurting, that's a different scenario. So it's hard to answer the question in a vacuum, but if the vascular studies are completely normal, there's a lot of other causes for heel pain that I think seeing a podiatrist can help clear that.
I think that her question ultimately comes down to, and it's probably helpful if I, because I deal with some of their questions all the time, is it seems like she's asking, she's concerned that here this doctor comes in, she has all these signs, she's been in excruciating pain with her left leg for months, and he comes in, he just feels her foot pulses and says, "You're fine. There couldn't be anything wrong with you." And just by feeling the pulses, can you tell whether or not a person has PAD? I think that's probably what she's asking. Or should she go and get a second opinion and get that ABI test or ultrasound?
Yeah, I would definitely get a good vascular study. Just by feeling the pulse, is not adequate, especially, there's a lot of other things that come with it. I tend to really do non-invasive studies to make sure I don't miss anything, because you could have, again, heel is a little bit unusual, but especially toe ulcers, you can have them with palpable small vessel disease. So to answer the question, just feeling adequate pulses doesn't rule PAD, and sometimes advanced small vessel disease for PAD. In general, if you don't feel like with your interaction with your doctor and they really ignore you didn't have a comfort, I think you should always get a second opinion, because I always try to, at least in my principle, to make sure the patient at least gets a vibe after I leave the room that I really try, even if sometimes I don't have all the answers, and I can just say, based on this stuff, I can rule out major stuff because I saw this and I saw that. Really, it's our job to really put the patient's mind at ease. Or if sometimes we don't know the answer, we say, well, I can tell you this, but I cannot completely explain your discomfort. So at least they get a sense that you didn't really blow it off. So if you didn't get that vibe, I think you should definitely seek a second opinion.
Douglas, go ahead and unmute and ask Dr. Karimi another question.
Yes, sir. I'm curious. I was talking to somebody in the group the other day about PAD, and I also described that I have CAD, and they asked me, well, how come? Because I told them there's a correlation. And how would we explain that for those of us also in the group with PAD that may not have CAD, but we hear these things? Most people with PAD have CAD. How would we explain that correlation between the two of them and how they go together?
Yeah, like you mentioned, a lot of people with PAD or peripheral vascular disease have coronary artery disease. It's a systemic disease of the vessels. As you get involvement in the leg arteries, and then you can get involvement of the heart arteries. So I have a low threshold in testing my patients with a stress test if they're having, sometimes the symptoms are non-specific. So make sure the blood flow to the heart muscle is okay. Like I told you, you can have CAD, but there are two types of CAD, what we call obstructive CAD, where their calcium is built up and it's really narrowing the blood flow. And you can have what we call non-obstructive CAD, where there's just calcium build up, but the blood flow is still through that calcium, and deposition in the vessel walls is still normal. So it's just extremely common. If depends on how you define CAD. If you just take calcium deposition in your heart arteries in a patient with peripheral vascular disease, I think the statistics are very high, probably over 70-80%. If you look at obstructive, meaning blockages that limit blood flow, you're probably looking at 25-30%. But it's very common. It's a systemic disease. It involves you. Sometimes you have carotid involvement that increases the risk of a stroke. You can have belly artery involvements with poor blood flow to the belly organs. They can have, pain with eating. It's just a systemic inflammatory process within the vessel walls, and it can affect different vascular territories.
Okay. And we have another question here that came in earlier. This person was diagnosed with PAD 6 months ago. She says, my numbers are stable from walking according to a recent repeated ABI. I was told to call if wounds develop before my next consult. I fell yesterday and jammed my big toe. It's swollen, it hurts. I can't bear weight, and it's bruised. Due to a heart attack 8 months ago, I can't take NSAIDs. How concerned should I be about it? I had sent you the picture at the patient's request via text.
Yeah, I saw the picture and I agree. It is bruised. So what you need to do is at least go see a podiatrist and look at, get an X-ray. What's important is really what's your toe brachial index. So I really don't know how bad was your PAD at the time 6 months ago. In general, a toe brachial index over 0.07, there is no concern for having any, and you don't have any open wounds. But what needs to happen is, and typically toe fractures, they don't need any open surgery, but it was very bruised and I saw it, and I think you should see a foot doctor, at least get an X-ray done. What I can tell you, and I've had patients that had very advanced vascular disease, and sometimes when they fall, they get these, bruises, or what we call hematomas. They can start pressuring the skin, and you can potentially, if you have bad underlying vascular disease, start having skin breakdowns under it. So it's very important, if you have vascular disease, this happens to you, at least go see a podiatrist, look at your numbers, get an X-ray of that toe, see if it's really fractured or not. If it's really not fractured, it's just bruised, it doesn't open up, and your toe brachial index are adequate, then you can just monitor it. But I would suggest to see a podiatrist, at least get a foot, get an X-ray and see exactly what's going on.
And we do have a very large studio audience again today. If you do have questions and you don't feel like being on camera, you don't have to. You can put them in chat. If you do want to actually be on camera, you can ask your question. Just raise your hand. And it looks like Alan has a question. Go ahead and unmute. Alan from British Columbia. Go ahead and ask your question.
Thank you, Kim, and thank you, Doctor, for being here and sharing your expertise with us. I'm getting on a plane in about 9 days, I think, and I'm flying to Mexico. Should I be wearing a compression sock on the plane? I've got PAD, anemia, and peripheral neuropathy, and I don't know if I should. I understand that when you have PAD, it's not good to wear compression socks, but I'm wondering if I should do it on the plane, or otherwise, if I should just make sure I stand up once an hour and walk around a little bit.
Or all of the above.
Well, yeah. Any advice on flying?
Gotcha. So that's a good question, because I get it not uncommonly. Sometimes people can have mixed venous and arterial disease. You can have venous insufficiency and you get swollen legs if you're, not walking. And you also have some underlying peripheral vascular disease. What we really worry about compression stockings in vascular disease is patients who have that are really, we're worried that if you put extra pressure and you limit that flow. In general, especially if your ankle brachial index, Alan, is above 0.7, compression stockings don't cause any problem. So if you, if your numbers are above that and you get on a plane and you get leg swelling, feel free to wear your compression stockings, and it will help prevent the swelling and doesn't cause any problem. This is a little bit overblown, and it's mainly for patients with ulcers that have also leg swelling. Which people can have mixed venous ulcers. So my threshold when I'm seeing wound care patients is if I have a patient who primarily, venous ulcers are more on the medial ankle or on the lateral ankle, they're not on terminal like toes, And if I look at the ABI, even they have vascular disease, peripheral vascular disease, I still feel comfortable. We have to sometimes wrap them in what we call 3-layer wraps. In those patients, I'm more cautious. I bring them in, in 3 days, take another look, make sure the wound is not getting better, to make sure I'm not putting extra pressure on. But that's the context. Not for patients who are walking with a stable CAD. If they get leg swelling, just wear 20 to 30 compression stockings during your flight. You wouldn't have swelling. In generalized, I think you're probably Vancouver to Mexico, probably 5-6 hour flight, right?
It's actually 4.5 hours. I'm flying from Kelowna near Vancouver. It's 4.5 hour flight.
Yeah. So,
Lost him.
Yep. Whoops. I think we lost him for a second. I was going to ask him to see if he could maybe get on his, if you have a cell phone. Dr. Karimi, do you have a cell phone that you can pull up that link and go ahead and maybe re-log in on that link so we have a better connection?
Sure. Let me do that.
That would be great. And while we're doing that, we do have quite a few more questions. Who in the live studio audience has additional questions that you want me to make sure that you get into this conversation? We do have a few from several people, I think, that are in this live studio audience that submitted them earlier. And I do have some slides that are ready to bring up to ask those questions as well. So I will make sure to ask them if you don't want to. But if you do, does everyone know how to raise that hand? If you do raise your hand, or if you have questions about raising your hand, go ahead and put it in chat and we can share with you how to do that. But even if those are on YouTube, I'm pulling up some of the YouTube to see if we have any comments coming in on YouTube as well. People who are on YouTube can go ahead and pull up the comments, and then you can write your questions in comments, or any comments you might have in comments as well. But if you are on YouTube, don't forget to like our video and subscribe to the channel to get notified of additional videos. But I appreciate everyone joining us, and he'll be right back on. You can never tell with technology what's going to happen. So I appreciate it. If you have any questions for me, I'm happy to answer any questions you have. We did start a Reddit group today. I don't know if you've ever heard of Reddit. I used to hear about Reddit all the time from way in my past. I didn't know it was filled with communities now, and there are quite a few people that are going there for help to prevent amputations. And so today we started a new Reddit group to hopefully capture those folks. And we do have someone in our midst that is our little Reddit angel that has saved 2 limbs, 2 people, and just the past 2 months have posted on Reddit that they were in need of an amputation and they wanted to prevent it. And whomever this Reddit angel is actually steered them to our website, and we were able to save the leg in both cases. And so we might as well have a presence there, right?
Yeah. Good idea.
So hopefully you have me back in.
We do. That is much, much better. Thank you so much, Doctor. You might want to turn that camera horizontal, or there you go. That's perfect. Okay, we can go ahead and get to the next question, which came in earlier today. It's again about the heart. What is the best test to have annually to check to see if the arteries around the heart are narrowing? I had a heart attack with 2 major blockages 10 years ago, but I feel as though the standard EKG and stress test aren't enough. I've heard about a PET scan as an option. Is there anything other than a full angiogram that will indicate if there is an actual threat? And that was from Nancy.
Yeah, great question. So, in general, if you have a blockage, when we clinically follow these patients, usually our decision to do a repeat stress test, or what we call an ischemic evaluation, is driven by the symptoms. So in patients in the category of what we call a stable coronary disease, we don't even routinely start doing a stress test unless the stent is in a high-risk position, for example, what we call a left main. Angiogram, we don't routinely do it because it's an invasive procedure and it carries its own risk. It's a small risk, but it's not without risk. PET scan is one of the newer ischemic evaluation that the benefit of it is that it has a much better resolution than a traditional, let's say, nuclear stress test, just because it uses positron emission technology. And so the false positive from a PET stress test is less than a traditional nuclear stress test. And you can also get other information, for example, calcium buildup, and how it progresses. But in general, this decision to do another kind of ischemic workup should be really primarily symptom driven. Unfortunately, in 2024, we don't have a tool that can predict. For example, what a lot of people don't know is that when you have a heart attack, a lot of the plaques that cause heart attack previously they just were 20% or 10% narrowing. But we call them vulnerable plaque. They have a thin layer on top. We call it the fibrin cap. And then it bursts, the body's natural response is to form a clot on top of it. It causes an acute occlusion of the vessel and causes a heart attack. Unfortunately, we don't have, some CT scans are looking at predicting which plaque going to have that, so you can preemptively maybe stent them. But we are not there yet, and we cannot really predict at this stage which plaque going to be problematic versus which plaque can we just observe.
There's some investigational blood work, such as the LPPLA2 marker, and also I think it's MMP9,
Gotcha.
I think was the other one. And we ended up getting that for my dad, which his cardiologist told him to get. And he was able to look at it and analyze it. And he said because of the results of those, he concluded that his plaque was actually stable versus unstable.
Got you. Those are good markers, but they're blood markers. They really don't look at the contents of the plaque that's, let's say, it's in the heart. But we personally check the lipoprotein A, and there's some studies hopefully next year that can have targeted treatment for lipoprotein A. Right now, we don't have any targeted therapy for lipoprotein A. But like you said, Kim, a lot of stuff hasn't materialized to be like broadly applied, and we're still trying to learn more about it.
And funny enough, and I see her looking right now, she's nodding, she knows she's already looking to unmute right now. We have Nancy, who is actually part of the Eli Lilly study, and she feels like she may not have gotten the placebo and has seen a dramatic reduction in her cholesterol, right, Nancy?
Yes, I am within 2 weeks after getting my injection, my LDL went from 77 down to 54. So I'm assuming that I didn't get the placebo. I'm hoping I got the medication. So to be continued. And I'm fighting hard. I've been fighting this for years. I'm just a huge battle. But I have peripheral artery disease. I have coronary artery disease. I'm a type 2 diabetic. My heart stopped. I was revived, and then I had a massive heart attack, and they put 2 stents in. I've had TCAR surgery. I have a stent there and a stent in my left leg. So I'm hoping, and I have very high lipoprotein A.
Yeah.
I'm battling, and I'm doing everything I can, walking 15,000 steps a day. So my concern is that, could there be more plaque around my around my heart and the arteries around my heart, because they don't give me stress test anymore. They don't believe in doing that unless I have symptoms. So I'm concerned, about that.
Yeah. I understand, Nancy, how it can generate anxiety. But studies that have shown that if you start just doing random stress tests and interventions in patients who have a stable disease, right, you could have potentially a 70% blockage. But by me going and putting another stent in, the results have shown that you can have more damage and potentially even trouble within the stent. So that's what I was saying, that it's mainly symptom driven, because we used to do a lot more stress tests. And, you might still hear it, but studies have shown that really more in patients who have a stable coronary disease. Not patients with heart attack, obviously, is different. With a stable coronary disease, And I have some patients that I know they have 70% blockage. They say, well, I go 5,000 steps, I'm really not bothered. And I'm watching them for a couple of years till their symptoms really, and we cannot control their symptoms with medications, then we'll do intervention. But that's the logic, because the procedure itself carries risk, and it hasn't been shown to really prevent heart attack or really provide significant benefit. That's why we don't do it routinely anymore.
Okay, so just watch out for any symptoms and keep seeing my cardiologist and my,
routine.
I see a lipidologist too, so, yeah. Okay,
It's still
thank you.
frustrating that half of people who suffer a heart attack show no obvious signs or symptoms. So
Mhm.
I'm still very confused by the evidence and the theories and
Mhm.
such. I know that I have my dad here because he did have a couple of interventions, and I feel very, very blessed with the care that he's gotten. 7 opinions to get to the level that we needed for his care. But you know, he's alive, he's standing, he says he's vertical and ventilating, which is so important, right?
That's true.
We have another question
Thank you,
coming
doctor.
in from Amy. And Amy's question: I have congestive heart failure as well as PAD. No one has ever suggested, oh, we're going back to the calcium suggested a calcium score. Should she push for one? And then she wants to know what annual tests you would suggest for congestive heart failure and PAD. So this one might be a little different than Marsha's.
Yeah. But like Marshall's question, this one, if you have PAD, I really don't see any value in adding a calcium score, because you know you have to really control your cholesterol. It doesn't change management. In terms of CHF, you know, if there are different types of CHF, one is systolic with the heart pumping function is low, one is diastolic with the heart muscle has problem relaxation. If you have the first type that's really low heart pumping function, I'm sure your cardiologist has done some sort of ischemic workup, whether it's a stress test or heart catheterization, because that's really, you should definitely rule out any heart artery blockage that can cause reduced function of the heart muscle. If you have peripheral vascular disease, it's a very major risk factors. If you have the other type, some people might not do it, but again, you have to look at the whole picture and other risk factors. I tend to do, if the patients are having any sort of chest tightness or shortness of breath, sometimes we call it angina equivalent. People can have just shortness of breath as their symptoms of underlying blockage. So a stress test, I think you should have done. Annual, it depends on, you know, for peripheral vascular disease, I do annual ultrasounds and ABIs because I want to see the progression, especially if I've done an intervention. My routine is after I do an intervention, I do 3 months, 6 months, 12 months, and then moving forward every 12 months. But that's the monitoring. And for congestive heart failure, probably at least an annual echo needs to be done.
Fantastic. Okay, we have 2 more questions that came in earlier for you. Let's pull this one up. This one's, and they saw a cardiologist and everybody wanted heart-related things because we always talk about general PAD, but I'm so glad everyone's talking about the heart, because 3 in 5 people who have PAD, have a heart attack, have PAD. So this is really important stuff, and I appreciate you entertaining these questions. This question is actually coming from Paula. She says, my symptoms have progressed over 4 years: fast heart rates, heart pain, chest pain, bad constriction in her head and arms, swelling, pale gums, lung tightness, bits of blood in her cough. Doctors really don't know what to do. What's going on? Wondered if you have any thoughts. And of course, I just need to preface it, as we did urge her to go get some urgent care and assessment at her healthcare center prior to this event.
Yeah, Kim, there's a lot of things that obviously are concerning. You really need to, it's really a very multiple symptoms that can be concerning. Heart pain, you know, blood in my, you know, sputum. This is stuff I think needs to definitely be looked at in more thoroughly. It's really hard for me to kind of answer the questions without a full examination and get a better clinical sense of the progression and details of the symptoms.
Right. We always tell them that that we will ask the question, but we do urge them to go and seek immediate care, because especially with those symptoms, those are pretty urgent. But she said, well, no one's giving her answers, so she wanted me to at least ask the question anyway. If you have any sort of foundation that she can jump off of in talking to her primary doctor or cardiologist to say, hey, I need these tests. Can
Yeah,
you
with
give me a
these symptoms, yeah, with these symptoms, you definitely want a, a ischemic evaluation, whether it's an exercise test, an echocardiogram, and then some blood work to just get a sense of where to start with, and then go from there.
Okay, and we have one more question that came in, and let's pull that up. Here we go. I have peripheral artery disease. One foot is swollen and red. Should I be concerned about this? Are there questions I should ask my doctor? And this came in from Shirley.
Gotcha. So to answer your question, Shirley, you should be concerned about it. In general, I think peripheral vascular disease, you can have a condition called dependent rover, where the foot really gets red and swollen. And you want to make sure that's not a blood flow issue, because especially if usually patients like this have a severe pain in their feet, unless they have advanced diabetic neuropathy. So it can be a manifestation of peripheral vascular disease. You should definitely see a vascular specialist. On the other hand, you can have peripheral vascular disease and venous disease. So you can have, venous problem that causes swelling. Usually those are not that red, to be honest with you. But overall, I think you should see your vascular doctor, have a thorough examination, see which one is clinically more suspected, order the right test. Because it can be seen, the swelling leg and the redness in venous disease, and it can also be seen in advanced peripheral vascular disease.
How do you tell the difference between the swelling from just basic edema versus a chronic venous insufficiency? I guess you just require the ultrasound to determine whether the valves are working or not?
Yeah, so usually venous swelling is not that painful at the foot level. If it's a dependent rover from peripheral vascular, it's usually limited to the forefoot. It's very red. It's like a bright red. Usually the congestion from venous is not as bright red. And usually when you look at the vascular numbers, you really have to have low blood flow, really low ankle brachial indexes, less than 0.5. To really cause that swelling and redness from peripheral vascular disease. Versus venous disease is more congestion, it extends to the ankles, and it's usually not limited to the forefoot.
Thank you. And if there are any other questions from the live studio audience, make sure to raise your hand. Make sure to put it in the chat so we can get to them, because we only have a couple more minutes here. Douglas, I think his hand is still raised. I'm not sure if you have another question. Go ahead and unmute.
Yeah, I kind of, we talk about walking, how important walking is to build collaterals. In the heart, if you walk, are you doing the same thing for your heart condition, or is it just building up your heart, or are we building collaterals in our heart in other places also?
Yeah, so good question. So, Doug, the heart beats kind of 60 to 100 times a minute. So it's not like your legs that you're just using the muscles when you're walking, right? So, but if you really exercise, and you can have blockages and you should still exercise, and we don't typically, recommendation for vascular disease is that if you get leg pain, you have a walking program, supervise and walk through it, and you walk longer distances. We don't have that recommendation from the heart. We just recommend that you do your exercises, stay active for the health benefit of it. But heart muscle is a little bit different than, vessels below the leg. You're right that they can have collaterals, these small blood vessels around the blockage. And by keeping active, you can, continue to reduce your risk factors. But we don't have that general supervised exercise program for heart artery blockages, unlike peripheral vascular disease, because the heart muscle is constantly beating.
And we do have a question coming in from Alicia right here in the live studio audience. Alicia, you might want to unmute and ask your question, because we might need a few more details, or else just be very conscientious and type away some extra details about this bypass and where it was. But
Okay.
she said,
can you hear me?
there you are. Hi,
Hi.
Alicia. Yes, we can.
Okay,
You had a
so
bypass done 5 months ago,
yes, go ahead.
and you're having pain at the proximal and distal end of the graft, and you're
Yes.
wondering if that's normal. What type of bypass?
Ooh,
Was
I'm
that
not.
from your, was
It's
it from
it,
your abdomen to your thigh, or your thigh to your knee, or your thigh to your calf?
it's from my thigh to my calf.
Thigh to your calf. That's called a femoral tibial
Yes,
bypass
that's
effect.
it. That's it.
Good job. Dr. Karimi, it looks like she's having a little bit of pain. Do you want to ask Alicia a few more questions to get a better understanding so you can offer some thoughts?
Yeah, so it was 5 months ago, Alicia. And do you know if they use your native veins or did they use a prosthetic graft?
My natural vein.
But that's good. Those are usually more durable. And you had, Alicia, ultrasounds done afterwards to make sure the
Yes.
flow through the graft is okay?
Yeah, it's patent. And also the vein that it's attached to, that has also been cleared a little bit too. My cardiologist went in and cleared that out. He took it from 90% to 30%. So it's patent and it's working very well, but I'm just experiencing very difficult, well, not difficult, but pain, like where it begins at and where it ends at. And I want to know, is that like normal during the healing process?
So I want to make sure I understand. You said your cardiologist went and cleared what?
The vein that the graft is attached to.
So they had to do an intervention on the vein graft afterwards, right? There was some
Yeah.
damage and they had to
Yes.
bone it. Gotcha. And how long ago was that?
That was done July 30th. So a bypass was done in May.
Gotcha.
And I went and seen my cardiologist, Dr. Fadi.
Gotcha.
And then he did the intervention on the vein that the graft is attached to in July.
Gotcha. Yeah, you probably mean on the artery that the graft was attached to,
Yeah,
right?
the artery. I'm sorry. I'm new to
I
this.
just want to
I'm
make sure I
still learning.
understand you correctly, and so I don't answer. So Alicia, I don't do open bypasses. I'm not a vascular surgeon, but obviously I see a lot of patients after the bypass is done. And, just at the incision site, obviously there's pulling and, pushing, and they have to obviously attach it. And so some mild discomfort as long as there's no significant swelling and the blood flow through the graft is okay, and you have seen your vascular surgeon and your interventionalist. Doesn't seem to be of too much concern, to be honest with you. And usually it gets better as time goes by. The most important thing is to have the good flow through the graft and make sure it's not compromised, which it sounds like you're watching it closely.
Yeah, I am. And then I have an appointment to go get my veins checked to see if everything looks good going down, but the concern is going back up because I still feel a high level of tightness in my foot and can't walk on it because there's not much feeling there, so I lose balance. I know it takes some time for the nerves to heal if they're not too damaged, but the tightness just makes me feel like maybe something is not circulating right. So I'm looking into having that checked out to see if the veins are circulating the blood back up correctly.
Gotcha.
Dr. Karimi, we always talk about, it's great you restore, inflow, but always ask your doctor to check the outflow. Would you mind talking about what that means and how to discuss that with your doctor?
Sure. So, when you have literally a bypass, you like you describe a femoral tibial bypass. So we always talk about blood going through that graft and coming out of that graft. Both of them are critical to keep the graft open. So when you have your graft from thigh to tibials, if you have any blockages on the bigger arteries on top, for example, your iliac arteries, that's called an inflow problem. So you want to make sure that that blood flow through that segment is okay. And when they attach it to your, below the knee arteries or tibial arteries, then you want to make sure those vessels that are the targets that are called outflow of the graft, they're open. So the resistance through the graft is not high and the graft doesn't shut down. So that's the medical terms that we use. How is the inflow? How is the outflow? And you want to make sure both are okay to improve the longevity of the graft and needs to be really closely monitored.
Okay. Okay. Yeah, that's a concern. Like I said, it just doesn't feel right.
Yeah.
You know, I'm good with it being patent, but it just feels like something's not right. So I have reached out to, I have a few doctors.
Yeah. No, I'm glad you're doing that. It is not uncommon to have swelling after surgeries. You know, there is manipulation also. You're not using that leg. You know, 70% of how we empty our legs is what we call calf muscle exercises. When you walk, the muscles squeeze the vein, help empty them out. So after you have any sort of surgery that you're immobilizing for a little while, you can have some swelling. But if it's more than what you would expect, and especially it's very painful, you need to really check all the boxes to make sure you're not missing anything.
Yeah, it
Okay,
sounds like
thank
they're
you.
going to check to make sure the valves are working to usher the blood back to the heart. Can you talk about why, while she's there, because I think it's maybe relevant, is a lot of times you don't realize that you have chronic venous insufficiency because you have you're struggling to have the blood going south. So you may not have the big rush of blood flow going north as well through the veins. Is the way one of the doctors described it. Can you talk about that? That's why we have a lot of patients that end up going in, they get the arteries cleared and they're like, oh my gosh, now I feel like, oh my God, there's a lot of swelling and what is going on here? And it's actually the veins, the valves in the veins.
That's exactly right. You know, when you have, I use the analogy that if there is not good blood flow going down and your foot was a desert and you suddenly open the floodgates and a lot of blood is going there, and the veins are not used to seeing that much blood going down. So you can get this condition when, you know, the foot pain that was from poor blood flow gets better, but now you start having swelling and you can actually have pain from just the amount of swelling that you're having. We call it the reperfusion edema. You know, you get more blood flow down, you reperfuse the foot, and then they get edema. In patients like that, I tend to have them actually wear a low-grade compression immediately after I open them up. So before they leave, I tell them, you know, expect your foot gonna get swollen, have their foot elevated, start proactively. It's much easier if you're proactive and give them compression socks, as opposed to, I'm not talking about high-level compression, even a 10 to 15 is enough to prevent that from happening. Otherwise, if you want to play, you know, catch up and their leg is swollen, it's hard for them to wear the compression stockings, it's painful, and they just don't have that smooth experience after you recanalize them.
So is it safe to wear compression socks after a bypass?
Yeah, it's safe to wear if you have a lot of swelling, you know, again, because I don't know the exact numbers, you should talk to your vascular doctors. But if you're having a lot of swelling and the bypass is opened, a low-grade compression, you know, would not really compromise your bypass grafts. But definitely talk, because I don't know the exact circumstances. But if the main problem is the swelling, and especially if they see some venous problems, then yes, you can wear compression stockings after you talk to your doctor.
And thank you, Alicia, for asking these questions. And we do have a couple just really quickly coming in from YouTube, so I don't want to ignore them. We have quite a large audience. I want to say hi to Tom on there, and also Peggy, and then I'll get to Lil Snappy's question. So Peggy, she wants to know if there's any sort of correlation between someone who always has a high platelet and whether or not that's an indication that you are going to develop peripheral artery disease or PAD.
Got you. So high platelet count or thrombocytosis can have a lot of, you know, causes. In general, it's not directly related to peripheral vascular disease. Having said that, you know, you can have conditions, for example, essential thrombocytosis, where there are really high platelet counts that can predispose you to blood clot formation. That's different than peripheral vascular disease, which mostly we're talking about the cholesterol buildup. So not directly related to peripheral arterial disease, but if the platelet counts are extreme, and also platelets are an inflammatory marker. So even if an infection can cause the platelet counts to transiently go up. So there's a lot in the mild range. So I don't know the specifics, but in general, it's not related to PAD, but it can cause blood clot in some special situations. But it can also be a very benign thing if it's mildly elevated during an infection.
And so if you do have this high blood cell count or this high platelet count, and you do start forming clots, they can end up with an acute situation with acute limb ischemia, correct, in the legs.
Yeah, theoretically, you can have
or DVT.
You can have a genetic predisposition, have some significant thrombocytosis. Those are clotting agents. They can cause DVT or an acute limb ischemia. You're right, but not peripheral vascular disease. And this,
No, not in general.
not like the context that you're talking, which is a stable calcium buildup.
Okay, and we have Lil Snappy, and I want to give a shout out to Tony, who joined in YouTube. It says hello, and also Mary, who says a big thank you to us for providing this opportunity. Lil Snappy, and then I'll get to Tony's question. I know you're probably running short on time, doctor, so I don't want to keep you too long, but we do have just a few more here. Lil Snappy wants to know if it's possible for leg hair to grow back after making the appropriate lifestyle changes and that circulation starts improving with those growing collateral vessels.
Yeah. Yes, there is. Like he mentioned, hair loss is one of the signs of peripheral vascular disease, especially in the lower calves. But you improve the blood flow and you're more active. Whatever gives you incentive to be more active and growing those hair back, it can happen.
And we have a question coming in from Tony. He wants to talk about the correlation between A1C. This is such a great question, between A1C and peripheral artery disease.
Gotcha. So A1C is a glycosylated hemoglobin that gives you an indication of how your blood sugar has been controlled in the past 3 months. So it's a marker that we use in diabetic patients to see how the blood sugar was controlled in the past 3 months. Well, as you know, diabetes is a very important risk factor for peripheral vascular disease. So people who have poorly controlled diabetes and elevated A1Cs are at significantly higher risk of developing peripheral vascular disease. So if you're diabetic, you really want to talk to your endocrinologist. So if your primary care manages your diabetes, you want to make sure you stay at A1C less than 7% to reduce your risk of developing or progression of your peripheral vascular disease.
Perfect. And we got a message. We'll get to Heinz as our final question of the day, but we did get a message in from Dee, who says that Dr. Karimi is awesome. She got so many questions answered she's had for years, and she really appreciated how you actually used medical terms and you didn't talk down to anyone, and that's so important. Heinz, go ahead and unmute and ask Dr. Karimi your question.
Hi, doctor. For those patients that have PAD for other than diabetes, they're prescribed meds and then they get treatments and all that, be it a stent or clean out or balloon or whatever else. And then in a lot of cases, it reoccludes. So my question is, if you're taking statins, you're taking blood thinners, you're taking Plavix, why do you need to keep doing that?
That's a great question. Yeah, it depends on the context. In general, if you look at bigger vessels, bigger vessels like the iliac arteries, which are in the belly, right? Those interventions tend to have a much better long-term patency. If you those are the areas, the vessels are bigger, most of the time we just don't balloon them, we actually stent them. And we also can use covered stents. So if you just look at the endovascular interventions, they're more durable. When you go to below, the hip joint, the superficial femoral artery, which is, let's say, from your hip joint to your knee joint, again, interventions are more durable than when you get below the knee. Our Achilles heel, and I'm focusing more on patients with wounds and very advanced diseases. A lot of the vessels below the knee, and especially when you get to the foot, those are super small. And we just had approval for the first approved stents below the knee, which is the Spirit stent, which is bioabsorbable. But a lot of times for this long segment of occlusion, we end up just ballooning them. We used to do that in the heart. We learned that they're not durable, so we now stenting the heart arteries. In the leg, the blockages, unfortunately, are extremely long when they get to the stages that they cause wounds that are not healing. So it hasn't been a practical solution to put a very long stent in the leg artery. They're between the muscle planes. When the muscles squeeze, they can crush the stents. So it's just a different dynamic. Whereas opposed to the heart, the vessels are on the surface of the heart. There's no going through different muscle planes that can damage the stents. So just it's a different animal, to be honest with you. I know they're both vessels, but the peripheral vascular disease is just a different animal than the heart artery blockages. So you're right. Depending on where the blockage is, in general, as you get lower to your ankle, those are not as durable. But a lot of times we do interventions below the knee for patients who have rest pain or ulcers. And, I've had patients that we did a very complex procedure. We opened it, they healed their wound, and they made lifestyle changes, and the vessel has occluded. That doesn't mean I need to go back in and open it up. As long as there's no wound, they're not having significant rest pain, they can go ahead and just have that wound, that artery still be occluded and still have, no problems afterwards. But I was trying, you had a very good question, but I was just trying to explain how the spectrum is different and how we think about it as interventionalists.
And I would love, you mentioned something very important for those that are watching that haven't heard this before. We actually have reabsorbable stents for below the knee that are FDA cleared. They're not in everyone's hands yet. It's by Abbott, and they're called Esprit. And I just wondered if you can just give us the synopsis really quick so people understand the indications for use and what is a reabsorbable stent?
Gotcha. Yeah, so it's, if you look at the stents that we use in the heart, they have a metal scaffold, and it's typically a nitrile, it depends on what stent you use, but there's an alloy. So that has a polymer coating that delivers the drug to the wall of the artery to prevent it from re-narrowing. What is unique about this stent Esprit by Abbott is that it is a bioabsorbable stent. So the scaffold of the stent is from a material called PLLA that over time your body absorbs it. So the benefit is that, a lot of times when we have a blockage, when we balloon it, because the vessel can have recoil and it actually can collapse on itself. Even if we immediately afterwards we look at it, we say it looks great. Studies have shown that if you look at it a lot of times 2 or 3 days down the road, the vessel has re-narrowed. So we always struggle with putting something in that can keep the vessel in. It's great if that thing can also go away, if after it does serve the purpose. And that's what the Esprit is. It's a absorbable stent, so it gives you it keeps your artery open, and after a while, sometimes can be 2 or 3 years, then the PLLA completely gets dissolved and you end up with the open artery. That's the promise, and that's what they got the FDA approval. I've personally used Esprit in 4 or 5 patients with excellent results. I believe in the technology. It's a very delicate stent to handle, and we call it, you have to have a very good vessel prep. So you really need to make sure you use the right size in the right locations. But it's a very good, tools that we have now that we didn't have a year ago to treat some of our more complex patients.
Yeah, and that's why we always say it's important that the doctors, especially when you're dealing with below the knee, that they use intravascular ultrasound, IVUS.
Yeah.
And it's just an extra imaging tool, and they go in there with they use audio waves, right? To get better imaging. They can check out the morphology of the plaque. They can tell you what type of plaque there is. They can better size the vessel. And so we always say, hey, doc, do you use IVUS for proper sizing and placement of the different tools that you use? Right, doctor?
That's exactly right. I can tell you, this has been a new trend, and I'm a big believer in it, and I use it a lot. But I've sometimes put 4 or 5 millimeter, stents or balloons below the knee that before I did IVUS, I would never do that, to be honest with you. So we have learned, all of us at Interventional, is that it's very important to appropriately size these instruments. And I'm glad we see from our community a little more push to really use it. Now, I can probably more than 95% of my coronary interventions, I do intravascular imaging, and we're kind of bringing that same concept now into the peripheral vascular disease. And I'm glad we're doing that because I think our results are more durable and reduces our risk for reintervention.
And already approved over in Europe, but not on the market yet over there. They're waiting for FDA clearance. You know where I'm going with this is with Reflow, the retractable scaffolding. So they're actually a removable stent, a retractable scaffold that they're literally in the whole FDA clearance process here. So we may see it mid 2025 coming to market, hopefully. Talk about that for a sec.
Yeah, so that's a very exciting technology. So, one of the, Peripheral Medical has this a stent essentially that has some spikes on it essentially, and especially for below the knee vessels. A lot of times we want to deliver the pressure to the wall of the artery and create what we call very controlled dissections. So some breakages in the wall of the artery that's very controlled, that's not erratic, that doesn't collapse the lumen with the appropriate sizing. And, Reflow Medical has come up with this, brilliant idea to use these spikes on the stents that you can, deliver these stents, and it can actually, hopefully in future, even deliver drugs through the wall of the artery for better long-term patency. I'm a very good, a strong believer that it really matters how you do your interventions. It's not just getting through the vessel. You want to really stay as much as you can in the lumen of the vessels. And these technologies that are really controlled and make purposeful, dissection. I used to also use another technology called Serenator balloon, which is, has this wires along the balloons that when I did my balloon expansions would really create a very nice luminal gain. That's what we all want to see, and less risk of recall. These technologies are moving towards that direction, especially if you can deliver drug also through this. It's very exciting, Rudy. I think I always tell my patient, I cannot think of the last time, honestly, I couldn't get through as SFA occlusion. There's so many technologies and tools. The Achilles heel for us is really below the knee, small vessels. So any technology that gives better long-term patency, like the other audience's question, as you get below the knee, your durability comes down. So we're really looking at what we need to do in terms of good vessel preps, good technology, better long-term patency, reduced risk for reinterventions. That's really the holy grail of peripheral vascular disease, and really having more durable and successful results.
Yes, definitely. And I do have 4 fun questions for some series if you have some time.
Sure.
Okay. But Alicia, just the final question here, but I can't let this one go because I do get this one a lot, and we haven't had a doctor answer this one. Are there any benefits to getting a spinal nerve block?
Not really in terms of from a peripheral vascular disease or progression of it. No, there's really no benefit to doing a spinal nerve block.
Yeah. Okay. So our fun question. So, walking is the best medicine. I'm curious if you have a story of a patient that was able to walk their way to prevent a procedure or prevent an amputation.
I'm a big believer, honestly, on walking exercises. And, I would say that if you get to the stages, Kim, that you have a wound, those are not, or significant rest pain, those are not the stages that I recommend, walking programs. Those are stages that I think the more you wait, the wound can get infected, bigger. But I have tremendous, success stories in patients who came with me with complete blockages. Their superficial femoral artery is completely blocked, and they're still seeing me 3 or 4 years down the road. They're still walking 5,000, feet, or even iliac artery, and you're just walking. They're walking further distances, and we're not doing anything. We're just observing them, and they don't have to have anything done. So just mere presence of even complete blockage doesn't mean we need to go in and do something.
Journey to Diagnosis. It's a series about that just represents the large number of patients that are misdiagnosed or they get to you too late. Do you have a single story of a patient where you just are still going, how in the world did this patient not get to me sooner?
Yeah, unfortunately, there are way too many, honestly, of these patients. You know, sometimes there is honestly access to cure. Some of the patients that come see us, they come from, you know, even I live in a major metro area, but you know, they come and they have a cut, they're diabetic, they don't pay attention to it. Then they go, they get antibiotics, the wound keeps festering, becoming bigger. By the time they get to us, the infection has expanded to the bone. Even if we revascularize them, they will end up with you know, at least a toe amputation, and then you have to hope that what you did is enough to heal a toe amputation. So time is tissue, I always say, especially if you develop a wound in patients with peripheral vascular disease. So I'm glad what you're doing, really increasing just your general awareness about PAD and how early, you know, interventions in patients who have limb ischemia and chronic limb threatening ischemia, what we say CLTI, is so important to prevent catastrophes.
And just two more quick ones. One is talk about a case. This is geared more towards physicians and clinicians, but still patients are listening. Talk about a lesson that you learned even the hard way. Could have been the right way, could have been the hard way. You know, in a case that you learned just a major lesson. Just a major lesson learned. It's for a series called The Pulse. It could be any case that you had that maybe something that you learned from that others can learn from.
Yeah, so you know, I have learned, and this has been lessons gradually learned since, you know, I started doing this now for 6 or 7 years, mainly focused on limb salvage. It's very critical to have a frank discussion with the patients and give them options. You know, what I mean is that a lot of times when I get a wound patients, you know, I see them, I schedule their angiogram. I do an angiogram and I, you know, look at it and I say, well, I can just go ahead and fix it right now. But I'm worried that there are some features that make this less durable, you know. And then I look at it and I say, maybe this patient goes and have a bypass as a better, more durable option. So, you know, as there are different categories of people who do this kind of work. There are us as interventional cardiologists, there are interventional radiologists, and there are vascular surgeons. And the few things that I've learned is that it's very important for me that mainly opens blockages with the stents and instruments, to have a very good trusty vascular surgeon that I can, you know, just say, you know, I can do this, but I'm worried about these features. And sometimes a bypass is really the better option, especially if the patients have native vessels. You know, there have been BEST CLI trial, which is a very major trial in our field, that described that if the patients have a good conduit, a vein conduit, like what the other audience had, the natural veins that was bypassed, these are very durable procedures. And sometimes they just come, they have one surgery and they get away with it. And as opposed to if there is a location I cannot stent or high risk features for plaque going down, making the condition worse. So I would say a good collaborator is very key. The other thing that I learned is that I'm glad I did it. I really study wound care very well. Like I told you, I'm the medical director. I think when you get to this field, you want to know how wounds heal. And it's just sometimes not just about the blood flow. So you can guide your patients. You know, I have patients who have a neuropathic pain or wound because they're diabetic, they don't feel it, they get a pressure ulcer, but also have peripheral vascular disease. Now I'm at the stage that I can really gauge how much vascular work I do, how much do they need to, a podiatrist needs to do in terms of offloading and doing the right things. So wound healing is very complex and not just about the blood flow. So learning wound care has been very critical for me. I've learned initially in my career, sometimes I was overdoing the vascular work that I needed to do as much, but also now that I understand the wound care aspect of it, I really tailor it much better. And collaboration is very key to have successful patient outcomes with a trustworthy open surgeon.
I love that you have wound care experience. It's just critical when it comes to these patients for diabetics as well as peripheral artery disease, peripheral vascular disease patients. But we do always tell our patients to make sure whatever procedure you have, that you ask the doctor, what is your contingency plan when that fails? Because they all fail at some point, whether it's 2 years or 10 years. You want to make sure that 10 years down the road, you still have a contingency plan if and when that bypass fails.
That's exactly.
And my final question, this one's really fun. It's really deep, and it just helps us to get to know you. What was that defining moment in your life, the catalyst for change in your life? We call it the 6 minutes that matter, and that's because of reflow, and you probably know why. So 6 minutes that matter. The defining moment, the catalyst, the conversation that you had that steered you in a certain direction. What was that moment that mattered for you in your career?
You know, for me, really switching, when I went to interventional cardiologist, I didn't think I'm going to be doing limb salvage and really advanced peripheral vascular disease. But, you know, it was, you know, one of my attendings who really got me interested in this, and really the relationships that I see develop over, you know, the type of relationships I develop with my peripheral vascular disease patients are very deep. They're really, you know, I'm grateful for the opportunity to help them, and they really connect with you because it is, you know, patients who have been through it, having so much pain or going to wound care center, it's no fun. So it's a sticking experience. And to be able to then see them now doing their own gardening, just doing the walking, have a normal lifestyle, is so gratifying. So for me, it has been the patient's outcome after we have had successful stories that really absorbed me to this limb ischemia and peripheral vascular disease aspect of it.
Thank you. Thank you so much, Dr. Karimi, for being here. We really appreciate you so much for spending so much time with us. We had quite the audience. And if anyone wants to get in touch, if they're in Northern Virginia, where do they go? Do you have a website or anything that they can get in touch?
Yeah, I mean, you know how to get hold of me, but
I
I'm
do.
part of Carrie.
I have you on speed dial now because you've already, within 24, 48 hours of us actually meeting through reflow, you actually went ahead and helped one of our amazing podiatrists, you know, with one of her patients. So we really appreciate you so much.
Absolutely, my pleasure. You know, they can just Google my name. I'm part of Carrie and Heart and Vascular, but in our practice, we have a commitment. Any patient with peripheral vascular disease, they'll be seen within 24 hours. We can make the commitment as long as they make clear that they have a wound and chronic limb threatening ischemia. We'll definitely get them in within 24 hours.
Wow, no, that's great to know. And if you want to get a hold of Dr. Karimi, yes, you can Google him. You can also go to just padhelp.org and go to our Find a Doctor page or go to our support page and just get a hold of us. And I will get a hold of Dr. Karimi and we'll usher you in if you are in his area. You can also call our Leg Saver hotline at 415-320-7138. If you are on YouTube right now, please, if you can, just take a moment right down below, just like the video if you would, and then also subscribe to our channel to get notified of more amazing events like this. And tomorrow morning, Wednesday morning, we do have Dr. Chris Seenan, world-renowned walking researcher, all the way from Glasgow, Scotland. He is going to be joining us on Wednesday, and you don't want to miss that to ask any question you have about how to walk effectively to grow those collateral vessels. But thank you everyone for joining us. And again, thank you so much, Dr. Karimi, from the bottom of my heart for everything you do to save life and limb.
Thank you so much, Kim. And thanks everybody for the opportunity.